My dad works in B2B marketing. He came by my school for career day and said he was a big ROAS man. Then he told everyone how much he loved calculating his return on ad spend. My friends still laugh at me to this day.
Not everyone gets B2B, but with LinkedIn, you'll be able to reach people who do. Get a $100 credit on your next ad campaign. Go to linkedin.com/results to claim your credit. That's linkedin.com/results. Terms and conditions apply. LinkedIn, the place to be, to be.
Well, hi there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and beyond that at the bedside. Today, we are tackling a maternal newborn topic. And before we jump into that, let's take a quick minute for our listener shout out. This one goes out to Kara, who says this. I just wanted to extend a thank you for all your amazing content. I started my first nursing school semester pregnant with my first kiddo and attended a nursing school about 2 hours away from home. I heavily relied on the Straight A Nursing podcast and Study Sesh podcast to reinforce concepts I learned in school while both commuting and caring for my little one. I graduated in early May of this year, passed my NCLEX in 85 questions, and have had my nursing license for about 2 weeks. In a few days, I will be starting my new grad residency in the ICU. I still find myself religiously consuming your content to prepare myself and also because you make so many concepts easily digestible. I truly attribute my success towards your content and will be forever grateful. Kara, thank you so much for submitting that. I'm so happy the podcast and the Study Sesh podcast helped you kind of multitask and study while you were driving to school and taking care of your little one. So I always tell people that are maybe thinking about listening to the podcast that it's not just for students, though, of course, I'm a huge fan of nursing students. I absolutely think you're all amazing. But as nurses, we're forever students, right? We're constantly learning. So it's for you if you're a nursing student, a practicing nurse, maybe a nurse who's jumping back into work. Maybe you took some time off. It's just a great way to learn and refresh. And I love that you can listen while on the go because I don't know about you, but I'm often on the go. And if you're curious what Kara is talking about, she mentioned the Study Sesh podcast. That's a whole other podcast that I have. It's a private podcast where I do pod quizzes and other things for dynamic recall to review a ton of material in nursing school. So I'll have a link in the episode notes so that you can check out Study Sesh. Alrighty, ready to dive into this maternal newborn topic? This one is on ectopic pregnancy. So an ectopic pregnancy occurs when a fertilized egg develops, but it implants somewhere other than that endometrium of the uterus. So ectopic pregnancies are not super common, but they are definitely common enough. They occur in about 2% of all pregnancies. And it's very important to note that pregnancies that occur outside the uterus cannot progress to produce a viable fetus. So there are actually several types of ectopic pregnancy. So the most common type is that tubal ectopic pregnancy. And in most cases, this is what's going to occur. The egg has implanted in a fallopian tube. And this is because that egg has gotten stuck on its way to the uterus. And this can be maybe because the fallopian tube is misshapen in some way or maybe inflamed. So it's abnormal in some way and the egg just can't travel as it normally would to get to the uterus. So it basically gets stuck and that is where it implants. There's also an interstitial ectopic pregnancy. And in this type, the egg implants in the fallopian tube, but it's in an area of the fallopian tube that is inside the uterus. So it's farther down on that path. And this occurs in about 5% of ectopic pregnancies. But far and away that standard tubal ectopic pregnancy is the most common type. And then we have a few other types as well. One is a cervical ectopic pregnancy. In this type, the fertilized egg implants in the lining of the endocervical canal. And this is pretty rare, accounting for less than 1% of all ectopic pregnancies. Another type that I found particularly interesting is the cesarean scar ectopic pregnancy. And this occurs when the fertilized egg implants in the location of that uterine incision from a prior cesarean section. In some cases, the pregnancy grows outward toward the bladder, and in other cases, it grows inward into the uterine cavity. And what I found as I was doing my research is that if it does grow into the uterine cavity, there is a chance that it could potentially be viable, but it will have some serious potential complications. Cesarean scar ectopic pregnancy is the most rare type. We also have abdominal ectopic pregnancy. In this rare form of ectopic pregnancy, the fertilized egg implants within the peritoneal cavity. We can also have ovarian ectopic pregnancy. This occurs when that egg implants on that surface of the ovary. This accounts for about 3% of all ectopic pregnancies. And then there's heterotopic ectopic pregnancy. And this is a rare condition in which there is an extrauterine pregnancy and an intrauterine pregnancy happening at the same time. In most cases, the extrauterine pregnancy is located in the fallopian tube when we have both happening at the same time, though it can occur in the ovary or the cervix as well. So again, several different types of ectopic pregnancy, tubal pertaining to the fallopian tube, far and away the most common. There's interstitial, cervical, cesarean scar, abdominal, ovarian, and heterotopic. Now, because about 90% of ectopic pregnancies do occur in that fallopian tube, that's what we're focusing on in this lesson. So from here on out, when I say ectopic pregnancy, I'm referring to a tubal ectopic pregnancy. Got it? Okay, so you might be wondering, I wonder who's at risk for an ectopic pregnancy? And that's a fantastic question. Now, there are lots of risk factors for ectopic pregnancy, but a really interesting thing that I learned as I was conducting my research is that it can even occur without these common risk factors present. So these risk factors include a history of infertility or treatment with IVF. And then another one is a previous ectopic pregnancy. Also, patients with a history of pelvic inflammatory disease, sexually transmitted infections, or endometriosis are at higher risk. Also, higher risk if there is the use of hormonal birth control or an intrauterine device, that's a big one, at the time of conception. Also, any history of fallopian tube surgery, such as a tubal ligation, would increase the risk. Smoking increases risk, as does being over age 35, and also frequent vaginal douching. One study I found showed that this can increase the risk of ectopic pregnancy by 76%. Alrighty, now that you know the risk factors, you might be thinking, well, what's the big deal? What are the complications of an ectopic pregnancy? Well, ectopic pregnancy is very serious. It is considered a medical emergency. It accounts for a little under 3% of all pregnancy-related deaths in the United States. Again, a medical emergency. As that implanted egg develops or grows, it places excess pressure on that delicate fallopian tube, which can ultimately and will ultimately burst, leading to internal hemorrhage, which in many cases can lead to death. So now that you've got some background on ectopic pregnancy, let's dive into the key things you need to know as a nurse or a nursing student, and we'll use the straight A nursing latte method to keep our thinking super organized and logical. So the first letter in the latte method is an L, and that stands for look. How does the patient look? Basically, What are the signs and symptoms of an ectopic pregnancy? So, the most common signs and symptoms of ectopic pregnancy are abdominal pain and vaginal bleeding in that first trimester. Now, the patient may also experience low back pain, cramping on that side of that pregnancy where that fallopian tube is affected, and weakness. And then, when that fallopian tube bursts, and it will if left untreated, this causes a sudden, very sharp, very intense pain in the lower abdomen. And because we have basically an organ that has ruptured, what do you think happens next? Internal bleeding. And then from there, we get hypotension. We can get serious hypotension, hemodynamic instability, loss of consciousness, all kinds of bad things. Obviously, if really left untreated, then death can occur. Interestingly, that buildup of blood in the peritoneal cavity can put pressure on nerves and irritate them, causing the patient to feel discomfort or pain in other areas. A lot of times, you'll see shoulder pain mentioned. The patient may even have rectal pressure. So the patient may have these kind of other signs and symptoms that don't seem related, but they actually are. And again, a ruptured tube is what? A medical emergency that requires prompt treatment. Okay, the next letter in the latte method is an A, and that stands for assess. So what are we going to do to assess our patient with ectopic pregnancy? Key nursing assessments for ectopic pregnancy include monitoring for bleeding, assessing pain, and keeping an eye out for signs of tubal rupture. So, when we're looking at monitoring for bleeding, how are we doing that? We can assess for vaginal bleeding, which can occur before that rupture happens, right? That was one of those common signs and symptoms. So, assessing for vaginal bleeding. And then if bleeding is severe, what do you think is going to happen to their volume state? It's going to be low. So assess for signs of hypovolemia and signs of poor perfusion. So a patient with hypovolemia and poor perfusion is going to have tachycardia. They're going to have a low blood pressure. And when you check capillary refill, it's going to be delayed. You could even notice poor skin turgor, dry mucous membranes, things like that. And then pain. We're absolutely assessing the patient's pain. You want them to rate their pain on that 0 to 10 scale and describe their pain. Where does it hurt? What is the quality of the pain? Prior to rupture, ectopic pregnancy causes abdominal pain. Now, the patient may just say, it hurts in my abdomen, or they may say it hurts more on my left side of my abdomen. Pain, or my right side, depending, of course, on which fallopian tube is affected. Pain may also be felt in the lower back in some cases. And then we want to look for signs of tubal rupture. So, tubal rupture, again, is going to cause sudden abdominal pain that is sharp in nature and severe in intensity. Comes on suddenly, sharp, and intense. Other signs include hypotension as that blood loss begins and continues. Patient's going to lose circulating blood volume. This is going to lead to hypotension. Ultimately, it leads to hemodynamic instability. The patient's probably going to be tachycardic. If hemodynamic stability gets very, very affected, though, bradycardia can occur because the heart's simply not getting enough blood and oxygen on its own to function properly. And then we could also have decreased level of consciousness. The patient may complain of dizziness. And again, as blood collects in that peritoneal space, we could have some of that referred pain, such as to the shoulder, for example. All right, before we dive into the tests utilized to evaluate a patient with ectopic pregnancy, let's take a quick break and then we'll come back for testing, treatments, and education. What's not to love about fall? The days are cooler, the cozy nights at home are longer, everything smells like pumpkin spice, and it's when I transition from lighter white wines into the reds. And my favorite reds are the Pinot Noir selections I've been getting from First Leaf. which is a personalized wine club that sends me hand-picked selections each month. In my most recent order, I received 3 bottles of Pinot Noir, one from California, one from Chile, and one from France. And I have to say, I couldn't even pick a favorite. They were all so good. It's like First Leaf knows my wine tastes even better than I do. I'm telling you, popping open a bottle of Pinot Noir, cozying up with my husband on the sofa, and watching a movie is my idea of a perfect evening at home. So to get started with First Leaf, all I had to do was fill out a quick questionnaire about my wine preferences, and then as I get shipments, I rate and review my bottles so they get to know my wine tastes even better, which means each shipment gets better and better. I'm telling you, it's like having a wine expert on hand each and every time I shop. So get cozy and pop open that perfect bottle of wine from First Leaf. Go to tryfirstleaf.com/nursemo to sign up, and you'll get your first 6 hand-picked bottles for just $44.95. That's tryfirstleaf.com/nursemo. tryfirstleaf.com/nursemo. So that next letter in the latte method is a T, looking at the tests that we utilize to evaluate an ectopic pregnancy. This is essentially going to include pregnancy testing, pelvic exam, ultrasound, and blood work. So the pregnancy test, this seems like a no-brainer. If an individual shows up in the ER showing these classic signs of ectopic pregnancy, we're going to do a pregnancy test and see, first of all, are you pregnant? And it will show a positive result. Next is a pelvic exam. Now, a standard pelvic exam in and of itself is not going to be diagnostic for an ectopic pregnancy, but it can assess for areas of pain, it can assess for areas of tenderness, and can even allow the physician to identify a mass on the ovary or the fallopian tube. To really get in there and see what we're dealing with, we're going to need an ultrasound. A transvaginal ultrasound is utilized to confirm the presence of an ectopic pregnancy. A transabdominal ultrasound may be utilized to assess for the extent of internal hemorrhaging. So you could see 2 different ultrasounds utilized. And then there are blood tests. So a key one is that serum HCG test, which usually rises less in an ectopic pregnancy than it does in a healthy pregnancy. So that's going to be abnormal. Other blood tests include a CBC. Hey, let's see how much blood loss this patient is having. We also want to look at Rh blood type, because if the patient is Rh negative, they're going to need treatment to prevent future complications should they have another pregnancy. And then progesterone. We're looking at progesterone levels, which if they're above 25 nanograms per milliliter, is very strongly associated with ectopic pregnancy. So again, those tests are a pregnancy test, a standard pelvic exam, a transvaginal ultrasound, and then a transabdominal ultrasound if we're looking to see how much bleeding is occurring, and then blood tests including serum HCG, complete blood count or CBC, Rh blood type, and progesterone. Alrighty, next in our latte method is the letter T, another T, and this one's for treatments. So in all cases of ectopic pregnancy, that non-viable fertilized egg must be removed or terminated to save the life of the patient. Some patients may be treated medically, while those with rupture or impending rupture or some reason why they can't have the medical treatment will require surgery. So let's talk about this medical treatment first. The medical treatment for ectopic pregnancy is the drug methotrexate, which you might recognize from learning about rheumatoid arthritis. And in most cases, methotrexate for ectopic pregnancy can be administered as a single dose, even in an outpatient setting. Now, it is only indicated in certain cases. So, first of all, the patient has to be hemodynamically stable. The serum HCG needs to be less than or equal to 5,000 milli-international units per mil. The mass must not be too large. The resource I found online stated that it needs to be smaller than 3 to 4 centimeters. And there is no fetal cardiac activity noted on transvaginal ultrasound. It's also important your patient who's going to be getting this medical treatment be willing to stay near medical services in case a rupture does occur. So you wouldn't want to give this to someone who says, hey, I'm getting ready to go backpacking on the Pacific Coast Trail for 6 weeks. No, they need to stay close to civilization and be near a medical facility just in case a rupture does occur. Now, there are some specific contraindications for methotrexate, including signs of rupture. We're not going to be doing medical treatment in that case. We're going to be going to surgery. If the patient has immunodeficiency, if they are breastfeeding, if they have thrombocytopenia or liver disease, they're not going to be getting methotrexate. Now, how does methotrexate work? It works by interfering with folic acid metabolism, and this inhibits DNA synthesis and cell reproduction. So basically, it stops the cells from growing, thus essentially ending the ectopic pregnancy, and the body then is simply able to just reabsorb that tissue. Now, side effects of methotrexate can be pretty significant. They include nausea, vomiting, diarrhea, abdominal cramping, and fatigue. And then some more serious effects include hepatic impairment, which is why we're not giving it to anybody with liver disease. It can cause alopecia, it can cause pneumonitis and pleuritis, among other things. Now, after methotrexate treatment, the patient must undergo serial HCG testing until values return to pre-pregnancy levels. So let's say you have a patient who says, well, I'm not going to go through those tests, then they're not going to be a candidate for methotrexate. Alrighty, so let's say your patient is not a candidate for methotrexate for any of the reasons that I've mentioned. Then they're going to get surgical treatment. So again, surgical treatment is going to be required for those who don't meet methotrexate criteria and in anyone experiencing a ruptured fallopian tube. And we utilize 2 procedures for this, generally laparoscopically, and that is the salpingostomy and the salpingectomy. Now, in a salpingostomy, an incision is made in that affected fallopian tube and that ectopic mass is removed. When you think of the word ostomy, think of an opening. Okay, we're cutting into it and we're taking something out. A key benefit of this procedure is that fallopian tube function can be preserved, so yay. But if the patient has a ruptured tube, they're going to need a salpingectomy. And this procedure involves removal of the entire fallopian tube, which does greatly affect future fertility. All right, our next letter in the latte method is the letter E, and that is for education because patient education is so important. So let's first look at patients undergoing medical treatment with methotrexate. It's really important they know the signs of rupture and that they absolutely have to seek medical treatment if any of those signs occur. They should also avoid drinking alcohol and even eating foods that can produce a lot of gas because this can mask the pain associated with a rupture. Other things to teach your patient receiving methotrexate are to avoid folic acid supplements and NSAIDs because these can decrease efficacy. And a common medication that would include folic acid would be a prenatal vitamin, for example. So no prenatal vitamins, no NSAIDs like ibuprofen or Aleve while you're taking this medication. And this is important for them to know because they could have that abdominal cramping because it's a side effect of methotrexate. I don't know about you, but when I have abdominal cramping, I reach for the ibuprofen. So you need to teach them how to deal with any of the side effects of methotrexate so that they're not decreasing its efficacy. They should also know that methotrexate can cause fetal death or serious birth defects if taken with a viable intrauterine pregnancy. This is why intrauterine pregnancy must be ruled out prior to methotrexate therapy. Remember, in some cases, we can have an intrauterine pregnancy happening along with an ectopic pregnancy. That's why we have to do so much diagnostic evaluation prior to treatment. Now, patients taking methotrexate can get a rash when exposed to the sun, so teach your patient to wear protective clothing and use SPF 30 or higher. And they should avoid sexual activity and vigorous exercise until that ectopic pregnancy has been treated. And they should know that a future viable pregnancy is possible, though they should wait at least 3 months before attempting to conceive and should probably talk to their doctor about it first. Now, what about surgical intervention patients? Obviously, we are teaching them all that basic post-op stuff, how to prevent infection, how to recognize post-op infection. And just to refresh your memory, signs of post-op infection are going to be things like fever, redness and warmth at that surgical site, purulent drainage, malaise, all those types of things. It's also important to ensure the patient understands that they are still capable of becoming pregnant after salpingostomy or salpingectomy, provided after a salpingectomy, they still have one functioning fallopian tube. Now, if both tubes have been removed, then IVF may be an option for future family planning. And you also want to ensure all patients with ectopic pregnancy know their risk of having another one is higher than average and that they should receive early prenatal care with any future pregnancy. And of course, with that, it's also really important they know the signs of ectopic pregnancy and to seek prompt medical treatment. All right, there you have it, your key overview of ectopic pregnancy. Now, earlier I mentioned Study Sesh as a way to review material for nursing school and reinforce nursing concepts. I also have an app, which is flashcards covering a ton of different topics. I believe there's over 5,000 individual flashcards, all organized by category and topic, subcategory, all laid out for you in an app. You can try it out for free with some sample questions in each category. Just go to your App Store, your Apple App Store, or your Google Play Store to download that for free. Just look for Straight A Nursing. I'll put a link in the episode notes so that you can easily check it out. And I really hope to see you back here next week, where we are going to be talking about the basics of UTI prevention in the clinical setting, a hot topic, something that if you've been in the hospital for even 10 minutes, you've probably realized is a key focus on any nursing unit. So we'll be talking about UTI prevention next week. See you then. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Have you ever wondered what the science says about certain foods, products, or treatments? Does chiropractic actually work? Should I only buy organic foods? Are GMOs actually harmful? Is adrenal fatigue real?
We've got you covered. The goal of the Unbiased Science podcast is to dispel misinformation and misconceptions across an array of science and public health topics. We love to debunk myths and help arm our listeners with information so they can make evidence-based decisions. Make sure to tune in to the Unbiased Science podcast to get all of your questions answered.